Yes, today is our session 6, and I had posted two questions last week to attend. I have received many answers from the people, but obviously I have to select one to discuss the answer. So the first case is Mr. Suzy is a 58-year-old gentleman who was found to have a lymphocytosis following a well-man clinic. He gives a 6 weeks history of tiredness and a few small lymph nodes palpable in his neck, which he has noticed in the mirror. He is still able to work full time and does not report any other symptoms. He has a past medical history of hypertension only, which is well controlled. So he is a fit man at the moment. His lymphocyte count is 12, and a blood film has been reported to show monomorphic population of small mature lymphoid cells with condensed nuclear material. His other blood counts are normal. No further action is taken for 18 months. Uh, at that time, the GP referred him to hematology. In the last 3 months, he has lost 1 stone in weight and has had to reduce his hours at work. So now he has become symptomatic. He toils very easily and is waking at night with sweats 2 to 3 times per week. So he has developed B symptoms as well. His full blood count is as follow. Hemoglobin is 102. So he has become anemic. Thrombocytopenic, platelet 95. White cell count increased 35 in 18 months' time. Lymphocyte count is 30. A CT scan shows widespread lymphadenopathy with 20 centimeter spleen. Flow cytometry shows CD19 plus, 23 plus, CD5 plus, 200 plus, 10 negative, FMC negative, and 79B negative. Now the question is discuss the management of this patient. Nowadays, the pattern of questions in the exam has changed. So I am sure that you will not get a full-fledged question of management like this. You will receive a question in the form of parts, um, like what is the differential diagnosis, is the next set of investigation you will do, what is the immediate management, what is the long-term management, like this. But still, there is a chance that they can give you a full-fledged essay question like management of the above patient. So the candidate has mentioned that patient diagnosed with chronic lymphocytic leukemia initially on wait and watch. After 18 months, he presents with constitutional symptoms and features which fulfills IWCLL criteria for further management. Yes, but mention here what features he has. Constitutional symptoms in the bracket, um, easy fatigue, sweating, weight loss, uh, thrombocytopenia, anemia, so that the examiner know that what are the features in this patient that make him suitable for the management. Now, the management include not only the workup and management here and management thrombocytopenia, you are managing this patient uh, as a whole. So, whenever we find any diagnosis in our patient in our practical real world, we do not go to workup directly. First, we have to explain to the patient that what we have found, what is the nature of this disease, and what will be the next step that we have to do. So you have to do uh, a breaking bad news to this patient that the investigations that we have up till now shows chronic lymphocytic leukemia, which is not an aggressive leukemia, uh, but initially it required wait and watch, but now it it needs treatment because this scenario does not mention that whether he has been informed previously that he has CLL or not. So if this patient was not informed about his diagnosis, I have to explain what is the diagnosis, what is CLL, and what we are going to do next. You have to give him some leaflet about CLL if he has not received previously. You have to give him CNS contact numbers for future contacts. You have to update his GP that we are planning treatment now for this patient. You have to request the GP in the discharge summary that we need an immunization program for this patient as well. So inform the patient that you have a CLL and now you have indications for treatment. Give him a leaflet of CLL. Give him the options of treatment, uh, what options you will use for the treatment, whether he is fit for the treatment or not. The scenario here explains that he has only B symptom. It means he is fit to receive intensive therapy. We have not been informed about the organ functions, but we have to check if he agrees for the chemotherapy. So patient wishes is also important in deciding the chemotherapy. Then we have to discuss this patient in the MDT. MDT would like to know whether this patient is having TP53 positive or negative. This patient organs functions are fine to receive chemotherapy or not. Whether he is IGHV mutated or unmutated. And what about the patient itself, whether he wants to have chemotherapy or not. And the patient beliefs, a religious belief as well, because this patient may be Jehovah Witness. So you have to do all the initial workup like this, explaining the diagnosis to the patient, giving him leaflets, CNS contacts, updating the GP, uh, pre-chemo test discussion with the patient to know his fitness for the patient, patient wishes, patient religious beliefs, because he may receive, he may need blood transfusion in the future. So you should be having all this information before going for further workup. If the patient wants to go ahead with the chemotherapy, yeah, so we will go ahead for the test. It is mentioned here CBC with the peripheral blood film. We have the CBC and blood film already, and the immunophenotype. So no need to discuss, mention this one. You need a hemolytic screen because this patient has anemia. So you need a hemolytic screen, which include retic count, heptoglobin, DAT testing, LFTs as well. You need virology screen because if you are planning the chemotherapy for this patient. X-ray chest, ECG, echocardiogram, lung function test you need if you um, want to plan chemotherapy for the patient. So to check the organ function, you need lung function test, ECG, echocardiogram, and X-ray. Lymph node biopsy is not necessary in CLL if you have confirmed diagnosis on the flow cytometry. This patient has cytopenias, so for bone marrow involvement, you can do bone marrow biopsy. Immunophenotype, no need to discuss uh, because you have done this one already. And once you do the bone marrow biopsy, the flow cytometry, cytogenetics, mutational status, TP53, RGHV, all of this will be done under the bone marrow biopsy. So you just mentioned that bone marrow biopsy for confirmation of the diagnosis, flow cytometry, further cytogenetics, and mutational analysis. Beta-2 microglobulin, yes. ZEP70, we don't do these days, ZEP70. Flow cytometry will tell us whether there is CD38 positive or not. Lymphocyte doubling time is not necessary. You have been mentioned in the scenario that the patient presented to you after 18 weeks, and this is the lymphocyte count. So no need to mention the um, lymphocyte doubling count. CT scan for chest, abdomen, and pelvis. I think the CT scan is done already here, so no need to mention CT scan again. Repetition will make the examiner bored, and it can affect the marking for you in the answer. Serum immunoglobulins levels in CLL, it is important. Usually they are low in the CLL patients, and uh, CLL patient usually get infections very frequently because of low immunoglobulin levels. So even after discharge, this patient needs to have regular immunoglobulin checks, and if they are low, we need to give them IVIG in our day unit. So this was the workup done for the patient after you have explained to the patient and he agrees to have chemotherapy, etc. Now, the management option. So, the performance score of this patient is important. We use the ECOG performance score here. This patient ECOG performance score will be 1 because he tires very easily, he has constitutional symptoms. So mention the score here, not say performance score ECOG. You have been given such a big scenario here, so you can work out what will be the likely ECOG performance score of this patient. So you can say the performance score ECOG likely 1. After evaluating comorbidities and TP53 aberration, you have been given comorbidities. This patient has only hypertension. To mention comorbidities in front of it, write hypertension. There is no other comorbidities mentioned in the scenario. So do not write a general answer. Address this patient who has been given to you in a scenario. TP53 mutation or deletion, as we have discussed last time, both are important, mutations and the deletion. Deletion is more common than mutation, but we have to mention here mutation and deletion, not aberration. Then we can write in general here that if the patient TP53 is mutated or unmutated, like in the guidelines, in especially in the heme base, they have given two categories: fit patients without TP53, unfit patient with or patients with TP53. So this patient, I would say, is fit. He has only hypertension, which is well controlled, and B symptoms, which is an indication for the um, treatment here, plus splenomegaly, and he has developed cytopenias as well. So in management wise, so give a heading that you are treating the CLL first. So if this patient has no TP53 abnormality, what are the options? Just write the option. We do not use FCR these days um, because it is an aggressive therapy and has many complications like development of skin cancers in the future and a requirement of irradiated blood. We do not use FCR these days. We have other options available now. We have VEN-I, which is 15 months fixed duration. We have VEN-O as well, according to the NICE 2020. We have acalabrutinib as well, and zanubrutinib. And if this patient has TP53 mutated, then we have options of VEN-O, again VEN-I, acalabrutinib, and ibrutinib as well, ibrutinib. Sorry. And the candidate has mentioned here if TP53 aberration M for targeted therapy with BTKI, BCL2, and PI3 kinase. We do not use idelalisib here in UK. It is very, very intensive therapy and a side effect of colitis and pneumonitis that can lead to patient death. So if you see the heme base has very nicely categorized the patient into fit patient with TP53 and patients without TP53. You can only mention the names of the chemotherapy. Do not say that you will use this one. You mention only the options of chemotherapy. The candidate has mentioned here localized irradiation for bulky lymphadenopathy. Our scenario does not mention any bulkiness. The patient has big spleen only and mention widespread cervical, axillary, pelvic lymphadenopathy, but he has no symptoms from this bulky or lymphadenopathy. He has only B symptoms. If it is not compressing any vital structure, nerves, vessels, and then no need to give radiotherapy to this patient. It will be a decisions of an MDT again in presence of clinical oncologist who will decide whether this patient is fit for irradiation or radiation or not. Then the second thing, this patient was having anemia. So we don't know whether this anemia is autoimmune hemolytic anemia or if this patient has anemia because of the bone marrow infiltration. So for that test, for this one, we have done that test previously to rule out whether it is autoimmune hemolytic anemia or not. If it is autoimmune hemolytic anemia, then we have to treat it as autoimmune by starting the steroids. If it is any other cause, like any hematinic deficiency, is there any other causes like GI blood loss or any renal insufficiency, then we have to address that particular cause. Um, if it is only the involvement of CLL as a cause of anemia thrombocytopenia, then we have to treat the CLL treatment. Initiation of treatment for CLL would address the anemia and thrombocytopenia as well. Then, in the setting of relapse, patient with CLL in home CIT fails may benefit from pathway inhibitors, combination therapy, and allogenic stem cell transplant. So, any patient who relapse, you have to uh, do all this workup again to see whether this patient is fit for further chemotherapy or not. You have to discuss with the patient whether he agrees for having further chemotherapy or not, and whether this is CLL. It has not been transformed to any advanced disease, rupture transformation. After um, these steps, then you can decide whether you can have chemotherapy or not for this patient. Do not jump to the options in terms of relapse directly. Any patients in hematology who has a relapse disease, they need full investigation, re-investigations, including bone marrow biopsy as well. Find out whether it is the same disease or it is a transformed disease. I'm talking about the non-aggressive diseases. And then patient fitness for the chemotherapy, patient wishes for chemotherapy. After all this, you can decide which chemotherapy you can use. Idalicib, we do not use here in UK. For the relapse, the guideline has summarized again very nicely, especially in the heme base. You have an option of WEN-R. Uh, according to the NICE 2019 guideline recommendations, you have acalabrutinib, you have ibrutinib, zanubrutinib. You can use this one in the um, relapse setting. After that, if the patient is refractory to these options, or if he relapse again um, after receiving the chemotherapy, or if he fail BTK or BCL2 inhibitors, then you can discuss the patient with the transplant colleagues whether he is a candidate for allogenic stem cell transplant or not. But for transplanting anyone, you have to check the patient fitness again, patient wishes again, and discussion in the transplant MDT. So every time in relapse, you have to start from the beginning in terms of investigation. Maybe previously he does not have TP53 mutations upon relapse. He may have got TP53 mutation. So uh, you have to investigate it from the beginning if there is a relapse. And then in the end, you have to give a heading of follow up. So this is your patient. You have to follow him in the clinic. He make sure he has a CNS conduct. If he has any problem, he can reach the CNS during hours and the hematology team out of hours. His GP is updated. He has full information regarding the CLL and the chemotherapy. Um, he is involved in the CLL societies so that he can get more and more information. Always discuss an option of trial with the patient. There are a lot of trials going on in CLL, so discuss the trial options with the patient. And uh, the other thing, important thing in CLL is the immunization. Inform his GP to start immunization for this patient according to the Green Book guidelines. As we mentioned in the early that CLL patient usually carries low immunoglobulins, so they are at risk of getting more and more infections. So that's why usually in your day unit you will see CLL patients receiving IVIG monthly because of low uh, immunoglobulins and getting frequent infection. Then you will complete the answers of any management question. Management does not mean that you do investigations and mention the treatment. No, it starts from the explanation to the patient, breaking bad news, comes to MDT, then pre-chemo testing, and then the first line chemotherapy for the patient. And then if there is any relapse, you have to investigate again everything. And then when the patient um is going home, then you have to write 5 or 6 points um, regarding his follow up in every management question. Then your management section is complete. Otherwise, you will fail the question if you write only workup and the treatment option. Any question about that? No question? Can you guys hear me?
Yeah, I can hear you. I don't have questions. Thank
Okay.
you.
Hello, Amir.
Yes.
Hello.
Mhm.
Yeah, Amir. Uh, Regarding idelalisib, even at relapse setting after second line treatment, aren't we using idelalisib though? Is there a place as a
We do
third?
not use idelalisib
We're
in
not
our trial
using, no? Okay.
because it has very serious side effects of
Mm.
pneumonitis and colitis,
Mm-hmm.
and which are usually fatal. So
Okay.
we have other options like BTK inhibitors. We have combinations um when O, when I, venetoclax, rituximab,
Mm-hmm.
um, like uh, far better options than idelalisib.
Okay.
And recently, we transplanted one CLL patient after he failed the BTK inhibitors and BCL2 inhibitor.
Okay.
I have seen only one transplant case for CLL in my trust.
Mm,
But idelalisib, we don't use it
mhm.
because
Thank
of the
you.
side effect. And if you see the heme base for the CLL current management, they have
Mm,
categorized it very nicely. Uh, I think it will help you in exam if you remember the CLL management section in heme
mhm,
base. But keep an eye on guidelines because CLL is the only uh, disease which is very rapidly evolving in terms of treatment. A lot of trials are going on. So after every 6 months, there will be some new addition to the treatment. So be updated with the CLL management.
Thank you.
So now the second question is: a 29-year-old man presents to emergency department with worsening fatigue, chest discomfort, shortness of breath. He, he has a previous history of rheumatoid arthritis. Full blood count shows hemoglobin 61, MCV 115, white cell count 12.9, platelet 181, and LDH 2000, ferritic 38. The blood film shows macrocytes, polychromasia, and spherocytes. So the first question is, what is the uh, differential diagnosis? So the candidate has mentioned differential diagnosis of megaloblastic anemia in rheumatoid arthritis. So I feel this heading is wrong. We don't know whether this is macrocytic anemia or megaloblastic anemia. The question has only asked about the differential diagnosis of this hemolytic anemia. The blood film, the FBC picture, the LDH shows that this is a hemolytic anemia. So the differential diagnosis would be either um, autoimmune hemolytic anemia and non-immune hemolytic anemia, which is the um, which can be either membrane disorders or enzyme disorders, or it can be um, oxidative hemolysis, infection-induced mechanical hemolysis. So basically, this question is asking you about the differential diagnosis of hemolytic anemia or hemolysis. So, as we mentioned, hemolysis can be immune or non-immune. Immune is autoimmune hemolytic anemia, and non-immune can be because of the uh, because of the either membrane defect, enzyme defect, uh, hematinic deficiencies, infections, or mechanical. So that would give you, or drug induced as well. That would give you the full set of differentials in this case. Now the second question is immediate management of this patient. He came with fatigue, chest discomfort or pain, and dyspnea, as hemoglobin is 61, which means that this patient needs urgent blood transfusion. So you have to uh, mention that this patient is symptomatic with anemia, which means he needs urgent blood transfusion. Now, the candidate has mentioned assurance to the patient. Assurance about what? Like you have hemoglobin of 61 and that is fine? No, write complete sentences. Like you are assuring the patient regarding this point. You are assuring the patient that you have a hemolytic anemia and we are investigating that to find out the cause for that. So the symptoms are because of the anemia. So we need blood transfusion for you. So when you explain to the patient that that your symptoms are because of anemia, and we are investigating the cause for it, you are opening a topic of blood transfusion to the patient. If this patient is Jehovah Witness, he would say, "No, I don't need blood transfusion." If he is not, then he would um, you would consent him and you can go ahead. So explain to the patient in the immediate management that you have symptomatic anemia. We are working to find out the cause for this, but because of your symptoms, you need blood transfusion. Uh, I would need to consent you for that blood transfusion. The important element of consent is Jehovah Witness, if you are Jehovah Witness or not. We need uh, a blood sample from you for cross-match, and we will try to find out uh, a group match blood for you. Because if this patient is having autoimmune hemolytic anemia, we may find difficulty to arrange blood for him instantly. So if the symptoms increases, his chest pain get worse, his ACG shows any signs of MI or other abnormality, then in that case we have to arrange an emergency pack for him. So immediate management, explaining to the patient what is going on, what is your next step, which is the arranging blood transfusion and consenting for blood transfusion. In case if the symptom get worse, we have to give you an emergency pack. We need to find out whether the chest discomfort is because of the anemia or not. So for that purpose, you will do an ECG, request an echocardiogram, send D dimers because he may have small volume PEs as well, and um, a short history from the patient to find out if he is losing blood from anywhere, um, any recent surgery, any recent admission to the hospital, um, hematemesis, black stool, a short history from the patient which can direct you about the cause of this symptomatic anemia in this patient. So these will be the few points: explanation to the patient, a short history, um, blood transfusion, consent for blood transfusion, in the bracket mention if not Jehovah Witness, urgent investigations like ECG, chest X-ray, uh, requesting for echocardiogram and D dimers, and questioning regarding blood. So that will constitute your immediate management. The patient needs blood transfusion because he is symptomatic. And the third question is investigate for the cause of anemia. Discuss any further investigation that will lead to the diagnosis. So if you see the BSH guideline, they have given a very nice algorithm for hemolytic anemias, especially for autoimmune hemolytic anemia, to find out whether this is an immune hemolytic anemia or non-immune hemolytic anemia. The first test would be DAT test, because you have your full blood count, you have a blood film. So the next test would be a DAT test to rule out whether it is positive or negative. Other supplementary tests in hemolysis are LFTs, heptoglobin, and LDH is already there. So that test would tell us whether this is autoimmune hemolytic anemia or not. And I suspect this is autoimmune hemolytic anemia because the patient has a background of rheumatoid arthritis, which is an autoimmune condition. Hematinics to be tested because B12 folate deficiency can lead to hemolysis as well. Iron deficiency can lead to hemolysis in very rare cases. It would lead to microcytic anemia, not macrocytic anemia. This patient is having rheumatoid arthritis, but we have no information whether he is on drug therapy for rheumatoid arthritis or not. So we can ask from the patient whether he is using any medications for his rheumatoid arthritis or not. Renal function test, yes, as an organ function. We have to find out for that. Again, a small history from the patient here would be important, whether he has any recent history of infection or not, especially upper respiratory tract infection or not. That can lead to hemolysis into the patient. Whether the patient has any background history of cancers or not, or recent admission to the hospital for any transplant, because these are the causes of uh, um, autoimmune hemolytic anemia. Any history of cancer, infection, autoimmune disease, and transplantation can lead to autoimmune hemolysis. Whether he has any background history of any membrane disorder, because he is 29, very young person, so um, he may have a history of hereditary spherocytosis or G6PD or any other unstable hemoglobinopathy can be there as a cause of um, hemolysis. So that would help you out in narrowing your differential diagnosis and help you to reach the diagnosis. But as we mentioned, that because of his background history of rheumatoid arthritis and hemolytic picture, it is likely that he would have autoimmune hemolytic anemia. If this question has mentioned that that is positive, then the scenario would be very clear that this is autoimmune hemolytic anemia. Now, the next question is regarding discuss the provision of blood support for this patient. So you need to give two headings here: uh, emergency blood transfusion, blood support, or urgent blood support. This patient currently is having fatigue, chest discomfort, and shortness of breath. So this these symptoms can get worse at any time. His chest pain can get worse, and you may need an urgent blood for this patient, emergent blood for this patient. So what will be the choices at that patient at that time? So if um, for the current symptoms of fatigue and chest discomfort um, and shortness of breath, if the patient can wait, then we can give him ABO, RH, and cell-matched blood negative for any current or previous antibodies as our protocol. But if the patient symptoms got worse, or if the ECG shows some changes of uh, NSTEMI, in that case you cannot wait uh, because if this is autoimmune hemolytic anemia, he would have um, IgG or IgM attached to the red cells that would delay the blood grouping, and usually such samples we send to the reference lab, and it takes 4 to 6 hours uh, to get the matched blood for the patient. So we cannot wait in such cases. Then we give them the emergency pack, which is the universal blood group uh, and universal blood for the patient. The candidate has mentioned here transfusion of 2 packs, which would raise the HB by 80. This is a wrong answer. Uh, the current protocol is to give 1 unit to the patient and review. He is 29. We do not know about his body weight. Maybe he is a very thin person. His body weight is only 40, or maybe he is a very obese person. His body weight is 120. We do not know about that. So the current recommendation from the NHSBT is to give 1 unit of blood and reassess the patient after 1 unit whether he is still symptomatic or not. If he is still symptomatic, you can advise another unit. If his symptoms has resolved, then no need for second unit of blood. So in terms of blood transfusion, you have to mention that ideally the patient need ABO-RH cell matched blood, cross-matched by IIT at 37 degree, negative for any current and previous allo antibodies. And if the conditions become uh, worse and the patient develop any life-threatening changes in the ECG or in the symptoms, that he need to be give uh, blood with universal blood group. So make two headings so that the examiner can understand that you know what to do in respective situation. That would give them you full mark. Then this was only regarding the blood product support. Now the question is regarding the long-term management of the patient. So the long-term management, the first statement here should be the long-term management of the patient depends on the cause of hemolytic anemia. If the cause is hematinic deficiency and non-immune uh, uh, hemolytic anemia, then address accordingly. Supply the patient with hematinics or address that cause particularly. But if the cause of the hemolytic anemia, which is most likely here, is autoimmune hemolytic anemia, then uh, the management is like this. Again, it is a management question. You have to explain to the patient what is the diagnosis, what is the result of the investigations, give a leaflet of hemolytic anemia. The patient would ask why I have developed hemolytic anemia. What is the causes for that? So you have to explain what is hemolytic anemia, what are different causes, it is primary or secondary, and give them a leaflet. And we have to discuss the need of blood transfusions in this patient because he may get hemolysis attack again in the future, and the patient may need blood transfusion in the future as well. So you have to discuss the risk of blood transfusion with them as well, which is mentioned in the consent form. And then, because this patient is symptomatic, uh, you have to start with the um, steroids first as a treatment option for hemolytic anemia, autoimmune hemolytic anemia. And you have to discuss the side effects and risk associated with uh, steroids. Again, with steroids, you have to mention that you have to take folic acid and gastric protection. Folic acid because of the ongoing hemolysis, you need your bone marrow need folic acid to replenish it. Gastric protection from steroid, bone protection from steroid, and if he is inpatient with hemolytic anemia, he would need thrombophylexis as well. And then uh, once you have confirmed that this is the um, autoimmune hemolytic anemia, while inpatient and in symptomatic patient, while waiting for the blood, we give them IV methylprednisolone and IVIG as well. If you can make a small heading uh, before discussing the long-term management, it would be fine, so that the examiner know that you know all about autoimmune hemolytic anemia management. So the long-term management would include discussion with the patient regarding diagnosis, giving him a leaflets, and the need of using folic acid and gastric protection and bone protection. And then if he does not respond to the steroid in 3 weeks' time, we have to uh, taper the steroids and then think about a second line option, which is the rituximab. For rituximab, we would have done the pre-chemo blood test during our investigations. We are usually worried that the patient may get a reactivation of any hepatitis infection or TB if the patient has previously. But before giving him rituximab, the usual routine is to do a bone marrow investigation in a patient to find out the cause of um, any other cause of um, um, autoimmune hemolytic anemia. But it is usually done in those cases where the cause is primary, not secondary. In our case, so there is a secondary cause, which is rheumatoid arthritis. So the first option is steroid with protection. And if the patient does not respond, is refractory to steroid or relapse on steroids, then the second option is rituximab, which has usually 4 doses over 4 weeks. And then the third option is immunosuppressant. And after that, uh, it is usually the discussion between the patient and the consultant regarding his fitness for aggressive therapy. But usually we reach to third line therapy, not far from that. Again, in the end, you have to mention that you have to give a heading of follow up, that you have to update the GP of the patient regarding his diagnosis and management, request the GP to arrange immunization for the patient. Then the patient should have a red cell CNS contact number. If he has any problem, he can contact the red cell CNS. Give him the required information about the hemolytic anemias, and the cause is secondary, which is the rheumatoid arthritis. So update the parent team as well that the patient has got rheumatoid hemolytic anemia, which we think is secondary to his rheumatoid arthritis. So if his rheumatoid arthritis is controlled, it is less likely that he would get a flare up um, of hemolytic anemia. And then that would conclude your management section as well. So the candidate has mentioned here, it is imperative to investigate the patient for the possible cause. The possible cause is rheumatoid arthritis, as per the scenario. Switching to other DMARD if methotrexate is the cause of megaloblastic anemia can improve anemia. This is the job of rheumatologist, not hematologist. So if you think that methotrexate is causing this problem, just inform the rheumatologist that the patient has developed hemolytic anemia and we think that methotrexate is causing the problem. Usually, methotrexate regimen include folic acid in it. Methotrexate is never given without folic acid. So, if you want to make any changes in the methotrexate, it would be by rheumatologist, not hematologist. So, that would then conclude your long-term management section. Right. We have 5 minutes for discussion. Any question? Again, can you hear me?
Can you hear me?
Yes, we can
Uh,
hear you, but I don't have questions. Thank you.
No.
Amit, just to get clarify that bone marrow, you said bone marrow doing if it's not if it's primary
If it
doing
is
bone marrow
primary,
in the secondary. Oh,
but if you
before
have a
the
secondary
second
cause, if you have a secondary cause, then we usually don't do bone marrow biopsy in autoimmune hemolytic anemia. The bone marrow recommendation is only for primary autoimmune hemolytic anemia.
Thank you.
So this was the meeting 6 for the um, part 1 essays, and I would again encourage you to participate and send me your questions so that we have something to discuss for the next meeting. I would wait till Wednesday. If I do not receive any question, then I will send out 2 scenarios uh, to discuss on the next meeting. But this meeting solely depend on the answer I received from you guys. If there is no answer received from you guys, I would have nothing to discuss um, in the meeting. So please send your answers. We discuss them anonymously, so don't worry. I would not take any person name. And making mistake here is better than making mistake in the exam. I know most of the attendees or listeners are from overseas. Uh, it is important for them to know what happens in the NHS and how to answer the questions. The exam is not only about knowledge, it is about tricks as well. You may be having a lot of information and knowledge than me, but if you are not able to organize it uh, in the exam in a way that they want, you will fail the question. So, this FRCPath exam is about knowledge plus more about tricks of attending the essays in part one and also in part two as well. Again, these sessions are free. Um, it will not be monetized currently. Thank you for your donations. If you want to donate, these are my accounts for UK and international candidate. In the last, please like, share, and subscribe our channel. It boosts us and encourages us. So see you next week. Thank you.
Thank you.
Thank you.
Thank you.